My name is Mehdi. I am a medical doctor by background. I'm a digital health professional. Been in digital health for the last 25 years. Worked across the planet, basically from Europe went to Mexico, implemented EMRs in Mexico, Chile, Argentina, went back to Singapore, lived 10 years in Singapore, did the national health records in Singapore, the Australian PCHR.
Yep.
Back to Austria, did the Middle East, and then went independent from corporate. I was Global Chief Medical Officer at Oracle until 2015. Left Oracle and been independent consultant with Seha, which is my company. We do independent digital health strategies, development, implementations, project management, and a lot of hand-holding operations and basically telling people what not to do.
You just jammed in like one of those elements someone probably could have talked about for 10 minutes at a time. So this conversation could go for hours if we let it, but we'll kind of hone it in. So you've seen a lot of healthcare around the world and digital transformation, and I guess over time as well. What brings you to HIMSS Europe this week?
Well, first I was invited by HIMSS to host a track, so it was a proposal I could not refuse.
Yes.
And it's an interesting track tomorrow. So we're talking about digital twins and things that are very, very, still futuristic, but very interesting. Talking about how to move from population health to personalized care.
Yes.
And these are sessions that are, I think, very, very interesting, not only to me, but also to talk about across audiences and cultures and different angles.
I was going to dive into this point around, because it's come up a couple of times in conversations, even just here this week. When we talk about population health, personalised medicine, is it an and or an or? Is there competing interests? Is there a priority of a focus on either? Because you could take either lens on it that, we need to personalise healthcare more to be at the individual level, and we can dive into genomics and personalized medicine, but then on the other end you've got the need for better visibility into populations, particularly communities of need that are probably underrepresented. Where do you sit on this kind of, is it a spectrum or a scale of like we need to be focused on the more grander population size, or do we really need to, is there more of an appetite in healthcare now to focus on specifically the individual now that we've got the power and technology to really do that?
I think they're not mutually exclusive. Both of them are actually complementary. You can't do population health without having personalized data or actually personal data. You can pseudonymize it. You can take the raw data for it. So basically, it's raw data that is used for population health. I'm an advocate for population health at the level of prevention, not so much on the curative side of the equation.
Yeah.
I've been a proponent of that strategy for the last 10 years. Unfortunately, the challenges we have are policies. It's always the policies that is a blocker, a roadblock most of the time, and then skills to deal with that topic. So it's never the technology. The technology is there.
Yeah.
It's just the policies that enable that. We've seen a lot of countries in Asia that are doing that. Singapore is a good one. And then people say, okay, Singapore, it's a small country, you can't compare it with us, whereas we're a bigger, more complex country, etc. But actually, that's a discourse I want to take on another, on another occasion.
Sure,
but basically, what we're saying is, to back to your question, we need to do both. There is a need to do both. The question is, can we do them at scale? So population health is done at scale, but can we enable personalized care at scale?
Yeah.
That's the thing. We'll talk about personalized care, and people think, oh, it's restricted. It's personalized, so only the few will get something. Think about longevity, right?
Yeah.
Anything that is longevity now is like we know the population. It's white males in Silicon Valley.
Yeah.
But that's it. That's population, right?
Yeah.
And that's
the hobby of longevity, I call it.
Exactly. So when they were young, they wanted to get rich. When they became rich, they wanted to get young again.
Right.
And so that's it. That's population health. That's personalized care.
Yeah.
But I think there is a possibility and there is a potential to make personalized care available for the masses, because it's not only the care as in the treating the diseases, etc., but it's also educating people in self-care. And then that's an angle I'm really advocating for, because we always think about data and technology, but it's not only that. It's part of the equation. The bigger equation should involve more self-care, more people taking care of themselves, but enabling them to do so by tools and policies.
Well, that's it, isn't it? Like, there's a technology element to it, but so much more of it, I think, is in populations that actually probably would benefit from when we talk about, digital literacy or educating people so they know better, but even that narrative almost of like, we know better, so we need to tell people what to do, or you're doing the wrong thing. I can't think of examples where that's worked at scale, where people go, oh, okay, I guess I should do better now. There's so much more human mushiness to it all, where, individuals have competing priorities or they're looking after others. And it's such a complex one to unpack that's still very tied to, I guess, technology and the implementation side. I'm not sure there's a particular answer, but maybe it's like the general human need to, if someone genuinely sees value or it helps them achieve a particular objective or a goal, then they're going to prioritize their health around it. Because at the moment, there's a lot of people who go to the doctor because they need to get a medical certificate so they can go to work the next day or something, or so they get paid, and that's really the extent of the time.
Of
what
course,
they think.
and I think we're more talking about the chronically ill patients, those who need the access to care services more often than others, and in a deeper, more engaging manner than others. The transactional stuff can happen all the time. That's probably 20% of the population that need transactional. The 80% that represent the 80% of the capital expenditure in healthcare, if you say, if you will, are those who need more durable chronic care for their conditions. And that's those that we should be targeting with self-care, with enabling them to see through things. Now, you touched a very interesting point, which is a paternalistic system. Basically, we know care, you don't. We deliver care to you, you consume the care, and we tell you what to do. It's changing. It has to change. So it's changing, but I always say you want to engage patients, but the engagement cannot start with the patient. It's the healthcare professionals that need to be more engaging and more engaged, and there's a crux there. And so, we always put it on the patient. The patient has to be engaged. How can we empower patients? But then actually, it's the other way around. It starts with the healthcare professionals engaging patients. When I used to do my rounds here in Paris, actually when I was a resident here doing my specialty, I used to sit on the bedside of every patient for at least 15 minutes in my rounds because I needed to talk to them. I had 38 beds of patients, 38 beds, and 80% of my patients died after 6 months. It was a hematology department. They had heavy diseases, and so they have to sit down with them and engage them because that's the opportunity for them to engage with them. That's the only thing they have. You can give them chemotherapy, whatever you want, but the human touch needs to be there. So if you want to engage patients, you have to be engaging yourself. So I always put it back on the provider to be more engaging, less paternalistic, and more participatory.
You can't sit an AI agent next to a patient on the bedside, right? Like it's
go down well.
Well, not yet anyway. So I'm thinking about what else we need in healthcare then to I guess enable some of this. Like they're thinking about the clinicians to be able to deliver better care, but also it's great seeing the ecosystem, particularly in the European region, coming together and make some connections. But what else do you think we need within the healthcare space to be able to, I guess, continue that momentum? Or like what are the kind of structures and things that we need in healthcare to be able to take things to the next step?
In my opinion, and it's my opinion, I've seen things around the world, and I think in the European Union in general now, in particular in the European Union with the HDS coming up, etc., technology is there. There is enough technologies. There is a lot of technologies around. We can use them. What we're still missing is the knowledge around technology and how to use that technology, and enabling people to understand it. Not even talking about health literacy, digital health literacy. I'm talking about the basics of understanding how technology works within the context of their practice. I'll give you an example. So a week ago, my neighbor came to me. He knows I'm a doctor, I'm a healthcare professional, a digital health professional. And he goes, I'm very comfortable that my data, my prescription is on my e-card, which is like a plastic card, right? The guy, it's not on a plastic card. He said, no, I went to the doctor and he made an e-prescription, and because the card was on the reader,
right,
when he finished the e-prescription, he handed back over the card to him and said, it's on the card.
Physically, right.
But it's not on the card. The card was an access key to the record.
Yeah.
And so the doctor got things wrong, confused the hell out of the patient, The patient came out confused, wanting to drop out of the health records because his data, he felt his data is not secure being on a plastic,
Yeah.
on a piece of
Right.
plastic. So all of that cycle, and this is one example, right?
Yeah.
So multiply that by the number of patients that this doctor sees, and amplifying the misunderstanding on how records are stored.
Yeah.
And that's a problem.
That's one example with one clinician too. Yeah. And then further on, that's even more. And
You can deploy technology, but if the technology is not understood by those who use it, namely the doctors and the healthcare professionals, that can have very nasty ripple effects on the understanding of the patient, their perception, safety, security, whatever. That's very important.
yeah. And hey, look, we were talking before we recorded as well about the potential to have different structures and communities of practice and things to be able to enable some of, I guess, this knowledge and capability. Talk to me a little bit more about your thinking there.
So today we have a lot of curricula about upskilling doctors, nurses, basically healthcare professionals in healthcare, digital health, and giving them certifications, what have you, the CP HIMSS and all this stuff that is happening. All this HIMSS is one example, but there are many, many curricula from Harvard to Cambridge, and everybody's doing these curricula. Problem of that I see is you get a piece of knowledge, you get certified, but then you're released out to the world and you're on your own.
Yeah.
There is nobody who could be a sparring partner for you to tackle a problem for which you went to do the certification, but then you come back and you have more knowledge, but you practically have nobody to deal to help you deal to help you deal with the problem.
Yeah.
Basically, right?
Yeah.
So the idea of communities of practice is to have at the end of these programs build communities of practice at the end of these programs, and have them come together to solve common problems and put these processes as an open database, open source asset for people to use. Problems are the same everywhere.
Yeah.
So that you help people, instead of starting to count from 0, start counting from 10, 11, because the basics have been already solved. You just contextualize and adopt and adapt. And so that's the idea.
Yeah, and look, I mean, this is always the challenge, though, right? Is that you can have communities or groups or memberships and things that exist, but it's got to be funded from somewhere, right? So normally there's a ticket to play. Like you got to be part of it, and you're talking about having an open source capability, and which would then enable like many others to be part of it. Those that might be otherwise not able to. It's interesting thing about how you would then fund something like that. But I guess there's good examples of open source communities and things that do exist. So
I think we're developing a model that is self-sustained right now. So in time we will be announcing that hopefully soon.
Yeah.
It's a self-sustained, well-funded model that I think will have some good impact on the communities of practice and the way we do certifications and deal with the problems in the community.
Yeah. Excellent. And lastly, what would you hope that people will be queuing up out the doors to be able to check out your session and your track tomorrow, no doubt. For those that are checking out the sessions that are on the stage there and actually just attending the event generally, what are you hoping people take away from HIMSS Europe this week?
I think more and more communities are coming together. People are coming together to talk about the same problems. I hope that anything that we talk about could be documented, and there is this genuine... I see a lot of discussions ending into let's collaborate, let's do things together. I hope these promises materialize. Yeah. Because people mean it. It's just that within this context, when you meet people here, it's easy to say let's collaborate, and then we go back to our day jobs and things get diluted with time. So my hope is that if 10% of those promises take place or happen, that's great.
It's a good reminder to anyone who's attended the event after listening to this a month or two after attending to jump back in and make those connections.
That's right.